Okay,
Yes, please.
that's
Yes,
thank you.
please.
Yeah. Hello, everyone again. Welcome to today's PhenoLab session. Today we welcome Professor Guilherme Messas with his talk Dialectical Phenomenology and Substance Misuse, its categories and clinical challenges. Professor Guilherme Messas is a psychiatrist and professor at Santa Casa de São Paulo School of Medical Sciences, Brazil, and national lead for Brazil for Collaborating Center for Values-Based Practice, St. Catherine's College, Oxford. Founding editor of the journal, I read the English translation, Contemporary Phenomenological Psychopathology. He has published extensively on phenomenological psychopathology, focusing on substance misuse and the use of phenomenological methods for diagnosis in psychiatry. He has a particular interest in training in phenomenological psychopathology, leading a 400-hour master's program in phenomenological psychopathology at his institution. Some relevant publications are The Existential Structure of Substance Misuse, a Psychopathological Study, 2021, Three Dialectics of Disorder, Refocusing Phenomenology for the 21st Century, 2021, The Dialectics of Altered Experience, How to Better Deconstruct a Phenomenologically Based Diagnosis in Psychiatry, 2022, and Phenomenology Yesterday, Today, and Tomorrow, a proposed phenomenological response to the double challenges of contemporary recovery-oriented, person-centered mental health care, 2022. So now the floor is yours, and we can begin.
Thank you very much, Degu, for chairing the session, for the invitation. And I should begin saying that it's been a pleasure for me to be here at the PhenoLab. This is the second time I'm here. And this second presentation is sort of continuation of the first one last year, as nobody is expected to have attended to my first one. I consider that this one is an independent one, but just in case, this is a continuation of the first one. Well, I will share with you my slides. The slides should work only as a tool for helping us. And I suggest that in case you want to dialogue with me, please feel free to do that while I'm talking. Though sometimes I say that, but I don't check the chat box, so I keep talking and talking, but I'll try to refrain myself of this excessive flow of talk. Well, in the next 45 or a little bit more minutes, I'd like to share with you, some thoughts concerning the problem of substance misuse from a phenomenological standpoint. That's why it's called Dialectical Phenomenology and Substance Misuse, its categories and clinical challenges. As you can see by the title, I will support here the idea of a way of performing phenomenology, which I called, following some forerunners, a dialectical vantage point of phenomenology. And I will try to highlight some aspects of this perspective that could help us as clinicians to better understand this widespread phenomenon of substance use and misuse. The idea here, as the title points out, is to focus on the idea of the categories, that is, the lenses through which we should capture this very heterogeneous and complex phenomenon, can help us by sharing, by focusing on some aspects of reality to better grasp these experiences and have, as a consequence, some deeper tools to face the clinical challenges this phenomenon put to our current daily practice. Well, this is the summary of the presentation. So the presentation has 4 steps. The first one, a short epistemological context of the problem. After that, also brief presentation on what I understand by dialectical phenomenology. And after that, the bulk of the presentation is the idea of using dialectical phenomenology in substance misuse. And I intend to conclude sketching some consequences for care that this perspective bring forth. Why the epistemological context in the first step? Well, as we all know, phenomenology as a current of thought has been called for in the history of psychiatry more as something to help solving some conundrums or some deep difficulties of psychiatry as a medical specialty or even as clinical psychology, rather than a mainstream current of thought. So understanding the reasons for using phenomenology to the substance misuse field needs to be started in some epistemology, in presentation of some epistemological context. Well, the paradigms, our paradigm builds their lenses, the way of grasping the complex reality of living, of existing. And if we follow the epidemiological need, widespread need for tackle the substance use and misuse problems around the world, we need to understand that we may understand that using substance is a global mental health, not to mention global health, but let's limit ourselves to a mental health problem. But though this widespread acknowledged problem of mental health, the interpretation of the problems of substance misuse is nothing but clear. I would dare to say that substance misuse categories, substance misuse problems is the field of psychiatry and the field of psychopathology as well as a basic science, as a foundational science for clinical psychiatry and clinical care. This is the less developed field in mental health. And this is a less developed field for many reasons. But for the purposes of this talk, I should say that for understanding the limitations or even the targets of the mainstream perspective of any perspective on mental health, but mainstream perspective on substance misuse, we should ask this perspective through 2 basic tenets of any paradigm, of any word interpretations of a phenomenon or of phenomena. In our case, particularly, I will stress the idea of diagnosis as a representative of the problem, of the limitations of the current mainstream paradigm on substance misuse. So if you analyze the current operational criteriological paradigm in substance misuse, and this is a very summarized way of putting it because we could develop it more and more through the distinct conceptions, say from DSM or for ICD. They don't overlap at all, but both have some peculiar characteristics or some common characteristics that entails this problem that I show to you here. We must face the problem that there are 2,000 ways to diagnose a DSM-5 substance use disorder. 2,000 ways to diagnose a situation entails also some sort of bizarre consequences, like this one, that two patients can be diagnosed and having the same diagnosis without sharing a single core feature of the criteria of, in this case, addiction. That is, what does it mean? What is the core of a definition that is not able to define? It's a sort of paradoxical definition if you consider that a person may belong to a category under 2,000 ways. Of course, there are some defense of this paradigm when some authors of this operational criteriological paradigm say that this has been developed to detect the amount of problem with substance use in a population. That is, the diagnosis, the main categories of substance misuse currently are tailored actually to respond to an epidemiological problem. And it's really necessary, of course, but there's a gap between what is an epidemiological detection of a problem, a widespread problem, and the real experience of the people who have been suffering for this problem. So I should say even that if there are problems with the operational criteriological paradigm throughout mental health, in this particular field of substance misuse, this problem is more conspicuous than in any other disorder, so to speak, like schizophrenic disorders or depressive disorders, and so on. This is the weakest part of the paradigm. And I will try to put forward in the next minutes maybe the reasons why this is the weakest part of the paradigm, which has to do with the complexity of this experience. So we not skip also the notion that under this sort of definition of criteriological, epidemiological definition, about half of people in need are having this sort of experience. This means, we should say that is a mankind problem. All of us are qualified for this definition. As far as I understand clinical psychology or psychiatry, I think, and that's why I'm using this phenomenological paradigm, that this is not enough for the current calls, mostly for the World Health Organization, for a modernization of mental health under the notion of person-centered care or person-centered recovery. In short, my point here is that to reach the needs of understanding a person-centered care, we need to change, to go beyond this operational criteriological paradigm in the search for a new paradigm. This new paradigm is an old one, is our topic here, the phenomenological paradigm. Well, in this comment to the Lancet Psychiatry in 2021, I and a colleague, Bill Fulford from Oxford, put forward some ideas to refocusing phenomenology, the very phenomenological psychopathology, for responding coherently respond to this current need of person-centered care. And we suggest that the best way for performing phenomenology, for understanding the person with all her characteristics, is a dialectical vantage point of phenomenology. Though I cannot fully develop all the categories, the relevant categories of this dialectical perspective on phenomenology, on phenomenological psychopathology, I can focus in one of these categories, which is one of this concept, which is this of anthropological proportion. So for the sake of simplicity and the purposes of this talk, I will consider here, I will understand substance misuse under a notion of anthropological proportion, which is not a new notion at all in the history of phenomenological psychopathology, though still underdeveloped as far as I understand this current. Which are the pathways for understanding the very complex phenomenon of substance misuse under a psychopathological perspective, though not against an epidemiological perspective. To do so, I defend that we should understand the person with substance use misuse or more severe problems with that under two simultaneous perspectives. And this, as a short note, this is one of the reasons, I think so, one of the reasons why this is so difficult to understand the problem of psychopathology of substance misuse, because we are required to have a double perspective, a simultaneous double perspective on these problems, which sometimes overlap and make things still more difficult, though there is a human logic, so to speak, in this comprehension. These two steps are, first, an unspecific account of the psychopathology of substance use disorders. In the second one, a perspective on specific psychopathological experiences related to substance misuse. By far, the most important is addiction. I begin defending that the first one is more important in terms of clinical practice and even in terms of epidemiological relevance than the second one, though the second one is considered the real alteration, addiction is considered as the real alteration of substance misuse. But I will try to defend that this is not the case. So let's go to the first one. To do that, we need to highlight some aspects of dialectical phenomenology, which will be of utmost importance for my thesis here. What is the focus of dialectical phenomenology? What is the aspects highlighted by the notion of anthropological proportions? Well, from this perspective, any psychopathological experiences should not be defined physiologically, mechanically, by the presence or absence of any behavior or even any experience, but rather by the dialectic, that is, the dynamics between relative proportions of poles of the experience, poles which are often intentions. This sounds too philosophical, but if you remember that the proportions of the conditions of possibility of experience are our usual temporality, spatiality, identity, which will be the more important, the three that I will develop here, though there are many others. An instance of that would be, say, the tensions between the openness of the future, the presence of the present, and the retention, the sedimentation, the roots of the past that we have in any experience, regardless of our will. This is one sort of proportions between dimensions of, in this case, temporality as a condition of possibility of existence. All of them, all conditions of possibility of experiences are subject to this very dialectic, to this very dynamics. Well, understanding the misuse of substance, such an universal experience as modification of consciousness, such a daily basis experiences of voluntarily modification of consciousness through any legal or illegal substance targeted to changing the neurophysiology of the brain, should be understood primarily as an act of empowerment of the person. So why that? Because first of all, every time someone drinks, say, pint of beer, there's a purpose of an act of self-management, an act of transforming the basis of her very experience. So primarily, changing oneself is the main global, anthropological, universal experience of using any substance. And though it's not always acknowledged, the first experience of modification of consciousness voluntarily is an expression of empowerment. Let's, for instance, use an example. If you, not today, that is still Tuesday, but next Friday, when you drink a beer or something like that with some friends, and you, or some acquaintances, not yet friends, and you drink for not only changing your experience, but also changing the experience of being with them, seeking, for instance, some sort of celebration, some sort of changing of the way you are open to the other, and the other are open to you as well. This is a very strong mode of dominating herself, of managing herself. This is necessary for understanding not only the use of substance, but also the way we will understand the problems that derive from this experience of empowerment. So using substance is not lack of power. Even addiction is not lack of power, but it is a problem of empowerment. Well, what are the main or the more usual aims of this act of empowerment, of this change of anthropological proportions? At least the most important for our purposes here. In terms of anthropological proportions, temporality is a very important condition of possibility of existence. We are temporal beings, and we cannot strongly manage our temporal beings unless we use some substance. For instance, with the purpose of domination of time dimensions. Say, we are very disappointed with our day. We are very disappointed some aspects of our life. We can't see a future. We can't see a light for our future. And we use some substance, we drink a pint more, and suddenly we can experience that experience. We can see a clear future in front of us. We exogenously, artificially bring forth an openness to our life that cannot be opened through without this artificial exogenous means. So, in the same for exalting, for instance, present. Let's consider that you were bored with such a boring conference and you need to drink more coffee or some other substance so that you can pay attention in what I'm talking now. This is a mode for making the present dimension more interesting that, for instance, our next commitment or forgetting our last commitment. By the same token, the notion of spatiality, that is the way any experience, be it a thought experience, be it an affective experience, occupies our field of consciousness. I call that spatiality. Is also an object of substance use. Through substance use, we can play with the complexity of our experience. We can, again, make, for instance, the ambiguous experience we have towards someone. The same example of drinking with someone, with a group, we can transform all of the members of this group into interesting people. We can forget, we can skip, overcome the ambiguous experience we have towards some of them. On the other hand, we can have also the opposite effect. We can have anger against all of them. But anyway, the experience of play with the complexity of the experience either transform this complexity into something more complex, or, which is more usual, reducing this complexity towards a target of ours. With this, I've used it twice, this example. I will not insist on this one. Both are subsumed, both are defined, are determined by temporal spatial conditions of possibility of experience, which change also our intersubjectivity and our identity. That is, what we are can be transformed through an act of empowerment. As you can see, for instance, this is some advertising of Brazilian Carnival. This is a picture of Rio de Janeiro's Carnival. One example of the Dionysiac parties which exist everywhere in the world, this changing of identity, the disguising of oneself that you can see here, and also here, this is another party, another carnival in northeastern Brazil, as you have similar experiences in your countries as well. Well, this possibility of modification brings about some vulnerabilities. It's important to highlight it again and again. The vulnerabilities are rooted in a normal, in an ordinary, in a regular, and a non-pathological act of self-management. It makes us understand the vulnerabilities not as a specific frailty of existence, though it can be the case, but as a general perspective, a general anthropological perspective, arising from a dialect between the subjective structure and the preferences or self-regulatory needs of this person. It is this dialectic, this power of changing the interrelation of the conditions of possibility of experiences that influences our use or our meanings searched by the conscious alteration. Vulnerabilities are also an existential characteristic of human to substance misuse. Some people, some periods of life are more vulnerable, but as a whole, all of us are vulnerable to this empowerment, to this uncontrolled empowerment. Well, from now on, I will just highlight I use some statements of a study we carried out here in Brazil with a vulnerable population about their experiences of substance misuse, in the case particularly with crack cocaine misuse, but as I understand, it's as a general useful also for understanding vulnerability as a human phenomenon. Let's see first the temporal risks, that is the temporal vulnerabilities. Dude, I don't know the sensation. If not all of them, most of them are homeless. Is a homeless population in the streets of mostly in São Paulo, Brazil, my city. So I don't know the sensation for people who use it, but I forget a lot of things. And this is a statement similar to the next one is adrenaline. Adrenaline, you run away from the world, you forget everything. Or with a little bit philosophical characteristics, when a drug user starts using drugs, he's stopped in time. He's not evolving in the same way that society is evolving. So it's a very needy situation, very much in need of many things. There's some microphone open. I'm not sure if I'm listening. Is it not an hallucination of mine? But anyway, I'm sharing with you. Sometimes it happens. Thank you for assuring me that it's not an hallucination of mine. So the main temporal risk is exactly this, is forgetting, leaving behind, stopping, not evolving, things against the usual characteristic of time experience that is divided in three aspects: past, present, and future. So there's a disproportion towards forgetting past and neglecting future. We will be back to these aspects. Spatial risk. This first statement is, for me, more important than the second one. The drugs fill my void. They make me interested in life. This experience of fulfilling the experiential field. Don't worry, Veronica. Thank you. Filling the void, transforming, particularly this guy, which is a very ambiguous person who was not able to be interested in life, transforming exogenous, artificially, a life with lots of voids in a fulfilled life, artificially. This fulfilling sometimes can enable the person, for instance, to face the street. Look again how powerful is this instrument. It helps to face the street, to face your fears. You're not afraid of anything. With a female, a homeless, female, a very vulnerable person. Well, and here, this leads us to the third feature that I like to highlight, which is for my interpretation, is the most important one for detecting psychopathologically the beginnings of a problem. If I would use the official clear-cut operational criteriological diagnosis, I would say that this is the perspective which it's an index, it suggests that we're getting into a real problem. Well, let's read it briefly. This is a female, homeless, who says that because here, the street is a world where we have no love, no family, no class, no color. That is all the differentiations a person has to be as a social person. This begins to dilute, to lose its contours, which also leads to a more complicated situation like this one, was clear stated by this non-intellectual person. You are no longer a person in society. Loss of identity is looking in the mirror and seeing that you haven't showered in 6 months. You don't have a haircut. You haven't shaved. My nails are rolled and have no clothes. I have nothing. But look, you're no longer a person in society. Self-defined as a loss of identity is a very deep comprehension of what I call biographical indifferentiation, which is for me is a landmark of the problem. It is a threshold of a problem with substance misuse. But this is not new. We, as a culture, know this for a long time, though we have not translated this knowledge into psychopathological categories. We left this apart in cultural representations like this one. Look, this the Baroque paintings of the myth of Dionysus or Bacchus is very important to show that. Though I'm not an art critic, I'm but a psychiatrist. You can see or help me to see that these representations of this young Bacchus has some characteristics of a child and of an adult, let alone an adult with problems. He's the way he bends on the barrel, the way he looks at the same time to the skies, though rooted in the earth and drinking as a baby should never do. Why? Directly to the bottle, by the way. This mixed of adult and infant, this myth between human and God, and a person and nature mixed up are constant characteristics of the representations of Bacchanali during all the Baroque. Not to mention in this one, which was the picture I chose for representing this talk, which is the Bacchanale from Pablo Picasso. Not only because of the mix between nature and people, but mostly because of this indifferentiation of a person, of people, this mixing, but also the mixing of colors, as if the colors were more important, or the sensation conveyed by the deep colors are as important as people who are in the Bacchanal. I will get back to this idea again. This is, for me, the best representation of psychopathology, of substance misuse in just one picture, that we psychopathologists should, at least could learn to go beyond the clear-cut categories of operationalism. Now, this is the name, sorry for that. Well, So far, we've been talking about some risks, some vulnerability, and some pathways leading to particularly disproportion of temporality, disproportions of spatiality, and a disproportion of, and a particular disproportion of identity and intersubjective relationship, which entails a biographical indifferentiation, which I summarize in these two classical pictures. Now, I suggest getting to the second, yes, sorry for that. This is a more general and probably the most relevant epidemiological problem in the population. But this unspecific condition overlapping with the ordinary lives of people can turn out to be something more severe and constitute a specific alteration of substance use, which I call addiction. Actually, the names I'm using here, addiction, substance use, or misuse, are awful names. The history of categories and the field of substance misuse is a list of tentative names to depict a condition which goes beyond the possibility of being grasped for a good category. I'm using addiction here because creating a word here would not be good, too complex. But addiction in its Latin origin, like the adhering to something, is definitely not the core experience which I'm trying to convey here. But I defend that there is a specific psychopathological entity which corresponds to a specific anthropological alteration, which is a modification, a structural modification, which can be defined mostly in terms of the simplification of the field of consciousness, which I describe here as the abolishment or the diminishment of the dialectical complexity of the grasp of reality. Though we're not, I don't know about your experience with the substance misuse care, but I'm sure that if you have any, you have this experience of someone who's using lots of any substance, missing their relationships, skipping jobs, living in streets, and when you try to help, or a family member try to help, the people say, no, I have nothing, and can't control, or something like that. Or even if you have, as a clinician, another experience, a very usual experience, at least for me, that is, you see this person in front of you, as in my case, a psychiatrist, and you start talking to this person, and actually nobody gets into the problem. The person is able to keep talking about any issues, but the issues that made the reason for being in a medical consultation. That's a very common feature, which I try here to depict in a formula of abolishment of dialectical complexity from the conscious grasp of reality. Well, there are two specific to this, if you want, disorder, if you want also some of you, disease, because it has a cause. It is caused by the use of the iterated use of a substance but it is not limited to the fact of getting the substance on a endless way. Actually, it has to do with two particular alterations, which are the utmost consequence of that vulnerabilities I pointed out some minutes ago, which can be seen from the temporal and spatial perspective. I would say, in summary, that addiction is a specific alteration caused by the use of substance, but defined not by the use, but by a transformation of the temporal condition of possibility of existence called hyperpresentification. And also, from the spatial perspective, defined by the notion of plenitude. That is an experience, conscious experience, which is only made of present and only made of plenitude, eschewing any experience which are related to past, future, or complexity, contradiction, doubts, or things like that from consciousness. Well, this is an altered state which sometimes resists to the interruption of the use of substance, which sometimes has sequelae, so to speak, in which there's a pathological present continuous. That is, that the experience of this person is an experience only related to the present. That's why, for instance, that if you have this experience, you make some deals with your patient for the next day. And though in the moment of this deal, the person is committed and you feel that the person is committed to this deal lasts for one day. The next day, the deal is over, like lost in the cloud. So, of course, this can also be seen, and sometimes this is the case, that the person is lying, is not interested. But I understand that this is rare. Usually the case is that the person wants to commit to a deal, but she has not the time, there's not the temporal conditions of possibility, that is the retention of the past to keep to this deal. This idea, this transformation of this temporal transformation of addiction, this present continuous condition, have particular distortions. There are many distortions, but I highlight three of them. One of them, which we use to conflate with dementia or with brain disorders, the idea of the cognitive losses related to substance misuse. Yes, it is true that there are many brain sequelae of the use of substances. But the point that I want to highlight is that we should discriminate between these brain sequelae, discriminate between what is brain and what is experience, though sometimes they overlap. A relevant part of the cognitive losses and also moral lack of commitment that we can see, as I mentioned, came out of this experience a present continuous. Now, if you don't have an pre-reflective transcendental experience of future, that is of a continuous commitment to something, there's no reason for you to practice your cognitive apparatus. That is, you don't need to have a good memory. You have a weak memory because you don't have the reasons for that memory. Though sometimes, again, this is a brain based rooted problem. Another character, I will limit to the second one. Also, we see this particular experience of substance misuse, of the distortions of substance misuse, of the severe psychotic distortions of substance misuse, which we usually call psychosis, which are distinct anthropologically, that is, ontologically distinct from schizophrenic or functional psychosis, because they are psychosis, as I call, by condensation. The anthropological origin of this alteration is not a break with the constitution of reality, as, say, in the schizophrenic experience, but also a condensation of the experience, which can be understood through the notion of spatiality. So there's a condensation, as for instance, if you go to a concert and the rock band plays too loudly and you leave this, you have this noisy after the concert for 1 day or sometimes 2 days. The idea of an enhanced materiality of experience. Well, we should say in short that the psychotic experience of substance misuse, mostly in addiction, but not necessarily in addiction, because there are some substances that make it different, are experiences of enhanced materiality. Anthropologically speaking, the opposite of the experience of schizophrenic experiences, which is of blurred materiality. And these experiences could be defined as a sensorialization sometimes of sentiments, the elevation of raw sensoriality. A clear example of the elevation of raw sensoriality, which entails some condensation psychosis, is some paranoia of crack users, crack abusers, the idea of listening to some sounds, or even some alcoholic problems. People see or listen to some sounds or see some image that they keep knowing that this can be originated by the use of substance. Though, of course, it's not a clear cut. Mostly in more severe cases, withdrawal syndrome of alcohol, everything mixed up. But the origin also of a severe withdrawal syndrome in alcohol is the opposite of psychotic functional experiences, is an elevation of the sensoriality of the world. Some final words concerning...
The kitchen is up and stable, so it's all prepared. When you're off this, I'll do that update. I'm going to get dressed and get that package out to the post office, and then come back and do my underwear.
Okay.
Yeah,
You have something at 1 o'clock.
I know.
All right.
What time is it now? 20 up?
It's 11:45.
Sorry? Was there a question?
I think no, that was not a question. I think we can
It's
go.
not okay. Sorry for that. Well, some last words concerning the idea of care, person-centered care, and recovery. Just some aspects. Well, if the problems related to substance misuse, as well as the most severe alteration called addiction, are, so to speak, alterations of the core of the experience in terms of temporal, spatial conditions of possibility. These disproportions are the core guiding line, the guiding thread to guide us for figuring out clinical care. So compensated imbalances that paralyze a personal existence is the core of a care, of a recovery. And the main concept for that is the concept of the repersonalization. What does repersonalization means? Means something that's very particular to this field, that this may be the only field in mental health in which if the clinician does nothing, the clinician does nothing. If the clinician is passive, the person normally gets back to life. Normally, it's not the case in severe melancholic experiences. It's not the case in the most cases of schizophrenic experiences, and you have to be active. In this case, no, you have to be passive, because it's the call is the nature, so to speak, of existence to get back to the trail of life, which it means that the resumption.
Is that down on the bottom or?
Again,
You want it?
No, forget about it.
Maybe you can mute her, or I
Alright.
cannot, but now you're host.
You want to put a little note in, like, here, I'll take that in.
Yeah, I don't want it labeled with my name on it, just a blank.
Recording?
I don't know. Well, I'm finishing anyway.
On one of these.
I sent her a message, but probably
Yeah,
she
I'm fine with it.
No,
Yeah.
A message to you.
Thank
No,
you.
I
Yeah,
couldn't
but you
see the
can mute
message.
her maybe. I cannot now, but
It says it's the APA on it.
Can I?
so maybe with this there is this
I
three
think it
dots.
started at a different time.
When you go to the picture,
Because this wasn't
and
going when I
there is three
speak
dots,
quarter to
blue three dots
12. It wasn't. It was
on
it was
the
already progress.
right corner up.
Oh, I'm not sure if I'm understanding. Anyway, just to finish. Yeah. Just to reduce the complexity of our experience without using substance, I should say that repersonalization is the target of helping someone with substance misuse and also with addiction. And the clinical challenge should bear in mind the sentence of this Mayo patient who states that when you get rid of drug addiction, it's like being a child again. So you have to deal with some experiences like this irritability, impulsivity, and depression, which are not necessarily caused by the use, but caused, if I am allowed to say so, for getting back to life, to getting back to the trails of life, like this female static that went into depression after interrupting the use because she had to face the characteristics of her life. Well, these are some aspects I would like to share with you. The developed ideas are published in this book from 2021. And I thank you very much for your attention. And thank you very much, Duigu, for sharing this.
Can you stop the recording there, or how can we stop it? Maybe because
No.
I cannot control it anymore.
No, it is still recording.
Yeah,
me.
we should stop now before the discussion. That's then
Should
we will
we?
go on with the discussion. Yeah,
Shall I?
please.